The topic, surgery in the elderly. These are my outlines. So we'll first discuss the introduction. What is aging? Aging is the progressive, intrinsic, universally prevalent physiological process producing measurable changes in the functions and structures of the body. I will go into the different changes that could occur, but just to note, the age of an elderly person is anyone above the age of 65. And this population of the elderly is increasing by the year, which then increases the need for care and hospital admission. Surgery in elderly presents a unique challenge and consideration, what will put into perspective due to the changing physiological functions. They need more evaluation and management, considering the complex medical functions they have, cognitive abilities, and possible comorbidities. The advance in surgical techniques, local anesthesia availability, and availability of minimal invasive surgery has improved the surgical outcomes as it has reduced the burden on the elderly patients. And let's look at the history of surgery in elderly. In the 60s and 70s, the surgical care for elderly patients was limited as there were few surgeons who could operate on elderly people. By the 80s, there was the Nigerian Society of Geriatric Surgeons. The Nigerian Society of Geriatric Surgeons was established, which then promotes specializing in the care for elderly patients. In the 90s, there was then the advance in anesthesia and surgical techniques, which then improved outcomes of elderly patients. In the 2000s, geriatric surgery became a recognized subspecialty with training programs established. In the present day Nigeria, there are Nigerian surgeons who are now more equipped to manage surgical conditions in elderly patients with a focus on minimally invasive surgery, local anesthesia, and multidisciplinary care. Now let's look at the physiological changes of the elderly, looking at the various systems. In the cardiovascular system, there's the decreased cardiac output, and there's also decreased blood pressure regulations. This then leads to increased risk of hypertension, heart failure, myocardial infarctions, and cardiomyopathy. In the respiratory system, there's decreased lung capacity and function. There's also reduced oxygenation and increased risk of respiratory failure. Let me put it as note here that the system of the elderly patients, they can tolerate stress, but there's reduced reserves, which I'm explaining here as there's decreased lung capacity and function. Reserves is little, so they can't handle stress as much as other ages can, which then makes us put more efforts and care into them. So in respiratory system, there's increased risk of pneumonia and other respiratory infections. While for the nervous system, there's decreased cognitive function and memory, reduced sensory perception, which increases the risk of dementia, Alzheimer's disease, and Parkinson's disease. For the musculoskeletal system, we have decreased muscle mass, decreased bone density, which increases the risk of osteoarthritis and joint pain. For the renal system, there's decreased kidney function, decreased ability to regulate fluids and electrolytes, which then increases the risk of acute kidney injury and chronic kidney injury, chronic kidney disease when there's an insult to the system. For the endocrine system, there's decreased insulin sensitivity and increased risk of diabetes. There's also reduced thyroid function and increased risk of hypothyroidism. And there's decreased adrenal function, which increases the risk of adrenal insufficiencies. For the gastrointestinal system, there's decreased digestive enzyme production and decreased and reduced nutrient absorption. There's also increased risk of constipation, diverticulitis, and other gastrointestinal disorders. There's in the immune system, there's decreased immune function and increased risk of infection. There's also reduced response to vaccine and thereby increasing the risk of diseases. Now, what is the problem in surgery in elderly. Surgery in elderly poses significant challenges due to the physiological changes that accompany aging, which I have mentioned above. Elderly patients have reduced physiological reserves, which makes them more susceptible to complication and slower recovery. The comorbidities, polypharmacy, cognitive impairment further increase the risk of adverse outcomes of surgery in elderly. As a result, surgery in elderly require careful evaluation, optimization, and specialized care to minimize risk and improve outcome. And how do elderly present? Elderly may either present as an elective case or an emergency case. The emergency case, it may present as cases of sudden onset, severe symptoms, acute trauma, rapid deterioration of a chronic condition. They could also present as sepsis or severe infection. They could present in shock, cardiac arrhythmias, and arrest. While for elective cases, they may present as scheduled surgery for chronic conditions, for planned treatment of cancer. They could also present as elective repair for hernias or other defects. Elective surgery will require preoperative optimization and comprehensive assessments, while emergency surgery will require rapid resuscitation and assessment, goal-directed pre-op care, which will now involve optimizing the patient and co-managing their possible comorbidities and reducing surgical risk. Let's discuss the preoperative assessment. What are the things that we would want to do before operating a patient? We will have to do a comprehensive assessment. That's where we'll take a detailed history, evaluating medical, social status about that patient, just to get an insight on what is going on that patient. We'll also do an extensive examination. After taking the history, if there is any medical condition, we'll manage this chronic condition like hypertension, diabetes. Then medication review, want to review what medications they are using, if they are on any medications like aspirin, if they are on any medications like antihypertensive, pacemakers. We also want to evaluate the cardiovascular system. Is there any cardiovascular risk in this patient? If there is, we would like to optimize the cardiac function. And elderly patients, as I described earlier, they have reduced cardiac output, so we have to put this into perspective. Also want to evaluate the pulmonary system, accessing their lung functions, and if there's any issue, optimize the respiratory status. We also like to evaluate the renal system, accessing for kidney function and optimizing fluid management. Then nutritional assessment, we have to ensure adequate nutrition to support healing. We would like to assess for possible risk, that's comorbidity, any comorbidity they have, frailty assessment, ASA, and POSUM. POSUM means abbreviation of some terms. P is for physiological score, O is operative severity, the double S is for surgical stress score, U is the urgency score, and M is the mortality score. I would also like to assess the cognitive function. The anesthetics will also evaluate and choose an appropriate anesthetic technique and measurement and medications. Then rehabilitation. This is just, considering rehabilitation to improve the physical function of the patient using the geriatric multidisciplinary therapy. Then finally, we'll get an informed consent. Now, moving to intraoperative care, what do we do intra-op? We monitor closely the vital functions. We pay close attention to the vitals, the oxygen saturation, cardiac function. Anesthesia intra-op, you also ensure the right anesthesia is used. Then body temperature, want to maintain as much as possible the normal body temperature for the elderly to prevent hypothermia. Again, they can't really handle stress as much as we can. The fluid management, careful management of fluids, to both prevent dehydration and also at the extreme, fluid overload. We also have to monitor the blood pressure, control it properly to prevent hypertension or hypotension intra-op, oxygenation, adequate oxygenation to prevent hypoxia, pain management, appropriate pain management to prevent discomfort, as pain can also depress the respiratory system, and antibiotic prophylaxis in order to prevent your surgical sites infections and possibly sepsis. In surgical techniques, we like to use minimally invasive technique and gentle handling of tissues to reduce stress and trauma to these patients. And blood glucose control, monitor the levels to prevent hyperglycemia and hypoglycemia. Would also like to monitor the respiratory care just to prevent the respiratory complications. Now, for the post-operative care, we need to do close monitoring their vitals, the urine input, output, then pain management to also prevent respiratory distress and discomfort. Fluid management to prevent dehydration and fluid nutrition support so that they can eat well, have enough nutrients to support their wound healing. Early mobilization, this helps in preventing post-op delirium and other cases. Other complications, respiratory care, wound care, delirium prevention, family support. This is very essential in elderly patients so that they can move early and have someone to depend on. And rehabilitation, after the surgery, they need to go back to have rehabilitation. To a slide showing the different pictures of the elderly. Possible complications that can arise from the surgery: post-operative delirium, which may present as altered mental status, confusion, disorientation. Respiratory complications like pneumonia. This pneumonia also comes under how it can be prevented is by early mobilization. Respiratory failure, acute exacerbation of COPD, then cardiovascular complications like myocardial infarction, stroke, arrhythmias, infection, surgical site infection, urinary tract infection, pneumonia, wound complications like wound infections, wound dehiscence, delayed healing, polypharmacy and drug interactions. Renal complications like acute kidney injury can also set in, an electrolyte imbalance if they are losing too much fluid, which can be managed by putting appropriate fluids. Gastrointestinal complications like ileus, bowel perforation, gastrointestinal bleeding, and long-term cognitive decline. Care for the elderly is multidisciplinary care. For the local experience, I looked at the statistics from 2019 to date. And if we can see for the general surgery, we can see as the year goes by, we have increased percentage, the amount of elderly patients that was operated on over the total number of patients operated. And we can see the gradual increments in the percentage of elderly patients operated on. And as it's increasing, this is most likely due to the improvement of the surgical techniques, the ability of minimally invasive surgery and local anesthesia use. So this improves. Mortality was 5 to 10%, which is an improvement. For the cardiothoracic unit, we can also see the increment in the elderly patients that was operated on and also neurosurgery. Now, in conclusion, elderly patients can't tolerate stress as to all ages, and so ages should not be a bias for proper medical care. We just need to put into perspective the different intra-op, the pre-operative care, the intra-op, and the post-operative care. Surgery in elderly presents unique challenges due to the physiological changes that occur with age. However, with careful pre-operative evaluation, optimization of medical conditions, and specialized pre-operative care, elderly patients can undergo surgery safely and effectively. These are my references. Thank you.
The presenter mentioned that appropriate anesthesia should be used for elderly patients. My question, sir, is what is the appropriate anesthesia to be used? Then for the preoperative assessment, you mentioned comprehensive geriatric assessment. Are there components one should take note of?
The appropriate anesthesia for the elderly, we want to keep the elderly patient as awake as possible So this is where regional anesthesia comes into play, like spinal, local, epidural.
Traditional and cultural problem with the elderly. Most elderly preoperatively will not accept surgery. Relations will not want that this man is old. The time is changing, so you have to take time, counsel them, and that is the work of the MDT, where the geriatrician and the surgeons all come together and talk to the parents, talk to the relative support before the surgery is carried out.
In the elderly, anesthesia for them is local or regional. This is because they do not metabolize drugs adequately. Some of them, the function of various organs decline as they age, especially the liver that metabolizes some of these drugs. So, for instance, you give them drugs like benzodiazepine, and again, in addition, they said that their albumin level is usually reduced. So they tend to have more free drugs because these drugs do not have enough albumin to bind to. So most times when you give them some anesthetic medications, the drugs have higher fold of function. So if the drug is supposed to act maybe for 2 hours, 4 hours, at maybe normal percent, the drug is now going to increase. It's going to act higher because they do not have adequate their albumin level has decreased and they have a lot of free drug in their system. So for elderly, when you want to give them anesthesia, you have to reduce the dose. You don't have to give them the appropriate dose that you will give to a normal patient because they will not be able to handle the medication quickly.
It's from hypoglycemia, this electrolytemia. So you don't want who will recover from GA. So regional is preferred because of the outcome. Patient-controlled anesthesia. Managing post-op pain is key in this scenario.
Post-op delirium in elderly patients. Given that an age above 50 years is one of the strongest indicators of post-op delirium. Other factors include general anesthesia, preoperative dyselectrolytemia, use of opiates, analgesics during anesthesia.
Your concern with opioid in the elderly. What is your worry about elderly having polyclinic? Most of these patients are likely having arthritic pain, and they may be exposed to NSAID, opioids. For the elderly, you must assess for those drugs. For opioids, our worry will be looking at constipation and the problem of addiction. You still need to look at that in the elderly.
The proper answer to it is that for patients, some procedures that you cannot do without general anesthesia, that for procedures that can be done under regional blocks or local, those ones will prepare to general. However, for those that would be, for procedures that you can't do without general anesthesia, then the anesthetics can go ahead and do general anesthesia. But they will be cautious with opioids, as we mentioned, adequate pre-oxygenation, preoperative chest physiotherapy, prophylaxis, converting drugs, because sometimes there are hypertensives, they are on blood thinners. So you have to now tail down those are on warfarin, those are on aspirin, reduce it up to when you use your Clexane, so that the patient will not bleed, excessively on table. And then post-operatively, analgesia is very important. Something like pain can cause delirium, and delirium can be very terrible to control in the elderly 65 to 74, aged 75 to 84, then very old 85. More than 85 years, very old, and 65. Start talking about elderly, but there are still subcategories.
About the importance of the geriatrics unit in managing some of these patients, not just pre-operatively, but even post-operatively. Post-operatively, for example, some of your orthopedic patients, some of your burns and plastics patients, they may be in a position whereby they cannot mobilize post-operatively, and that can also, make them prone to developing pressure injuries. It needs to be taken into account, bowel care, bladder care.
Even modification of the elderly home, from using WC, from living upstairs to coming downstairs.
Remind all of us that some of these issues are not just, pre-operative issues, So pre-op, intra-op, post-op. Try and take the patient as a whole. Thank you for the presentation.
Number one is the issue of dignity. I had several elderly patients who refused surgery. It's just the matter of approach to them. A lady who had a partial stroke, just because they told her that, Madam, you just have to walk. She just refused to walk. And then when one time there was nobody and she's pressed, she wanted to go to toilet, she tried to move and fell down and fractured the head of her femur. So dignity is very important, especially in our community. So please, young doctors, anytime you see an elderly patient, whether in the clinic or in the ward, you must try as much as possible to preserve his dignity. And that dignity, if you do not take care of it, you talk to him anyhow, roughly, he will say, who are you to talk to me like that? Imagine former president, you come and tell him, man, just remove your trouser. And you do not provide privacy and you do not talk to him gently. So dignity is very important, especially in our culture. The second aspect, especially for the young doctors, is that an elderly man with cholecystitis, acute cholecystitis or acute appendicitis, 1/3 of them may not have fever. Even if you take their blood, 1/3 of them may not have raised WBC. So those clinical parameters, you should always take it with a pinch of salt. So many a times we can arrange to do exploratory laparoscopy, not exploratory laparotomy. So that improves issue of the elderly. I think other issues of the comorbidity, frailty, dementia, and always please remember, you are an orthopedic surgeon, you are a general surgeon, you do surgery, you want to mobilize the patient the following day. For the elderly, they can have problem with stability. So for them, you must consider, even if you think that, I have done fantastic surgery, tomorrow the patient should stand up and walk. The orthopedic, and sometimes we neuro, we boast of that. But we forget these are already an elderly patient that may have some form of instability. So these are the two areas.